Good afternoon, ladies and gentlemen. It is my privilege to have the opportunity to discuss on the topic ultrasound for renal artery stenosis. I'm Leandro Fernandez from Venezuela, and I'm WFUMB Center of Education Director for Latin and South America. Let's begin with some general comments regarding renovascular hypertension. This is the most common cause of secondary and curable hypertension. According to the international literature, these cases can be between 16 to 29%. Atherosclerosis is the cause in patients over 50 years, and 80% of lesions are located in renal proximal segment, almost 90% of them. And fibromuscular dysplasia is the cause in younger patients, less than 40 years old. And the lesion can be located anywhere in the renal artery, 10% of the cases. So, renal Doppler is a non-invasive imaging modality which allows assessment of resistance index. It can evaluate the renal function, and we can perform this study independent of the glomerular filtration. Let's see some information regarding instrumentation and technique. It is recommended to use convex broadband transducers with a frequency of 6 to 1 megahertz, but it's also possible to use a transducer with 3 or 3.5 megahertz. The sample volume must be adjusted to a distance of 2 to 5 millimeters. We have to decrease the wall filter in order to explore the parenchyma, but we have to increase it when you are studying the renal artery. The spectral analysis scale is better if you use a big size of this scale, and you can obtain that by decreasing the PRF. In many labs, it's recommended 6 to 8 hours fasting. In ours, we recommend liquid diet. The study is done in supine and lateral position. The objective is to visualize veins and arteries. The time for the study is 10 to 20 minutes if you are trained and you have a good equipment. If you are in your learning curve, probably you can take 30, 40, or even 60 minutes. We also do this recommendation for our patients: a 3-day diet before the exam with no beans, fried foods, cabbage, cauliflower, and dairy products. Simethicone, 1 capsule with each meal, and plenty liquids the date of the exam in order to avoid gas. The assessment protocol has 2 steps. The first, indirect method, we have to observe the intrarenal hemodynamic changes, and the direct method, the renal artery hemodynamic changes. We have to study all the vascular net, the renal, the segmentary, the interlobar, the arcuates, the interlobular arteries. Here we are observing the intrarenal veins and arteries, and here it's evident that we can see the renal vein and the renal artery. By using power Doppler, in this case bidirectional power Doppler, we can observe all the path of the renal artery from the aorta to the ileum portion of the kidney. We can also observe the vein. In the indirect method, we have to study all the vessels inside the kidney. And then we can obtain the spectral analysis, and the computer provides all the hemodynamic information necessary to do the proper diagnostic. Here we are placing 2 calipers in order to calculate the acceleration time and the acceleration index. The direct method allows us to see all the path of the renal artery in the three segments: proximal, middle segment, and distal segment. And we have to place the sample volume in each portion I mentioned. Here we have an example placing the sample volume in the middle segment of the artery with a completely normal spectral wave with an empty spectral window. The spectral analysis allows us to get two different kinds of waves. One wave inside the parenchyma, where you can see how the spectral window is filled by the signal. And here in the renal artery, the spectral window is empty. This is the normal finding of the two different vessels inside the parenchyma and the renal artery. The spectral analysis allows us to obtain the indices and the velocity. We have to make measurements in the three segments of the kidney: the upper pole, the middle portion, and the lower pole. And in the artery, we have to obtain at least three measurements: in the proximal, in the middle, and the distal segment of the renal artery. It is important we all remember that we have different renal wave patterns. Those patterns, type A and type B, are normal. But here the lesson is that we have to place properly the calipers. We have to place one caliper at the end of the diastole and the second one on the peak of the initial wave, independent of the morphology of these patterns. This is the proper way to place the calipers and obtain a reliable and a confident measurement. The renal arteries are first assessed by using B mode, and then we activate the color Doppler. In thin patients, we can obtain this special view. It is called banana peel sign with color Doppler, and here with power Doppler, bidirectional power Doppler. And then we can place the sample volume, then obtained a normal spectral wave, and the spectral analysis says that we have a normal velocity of 78 centimeters per second. This is a normal renal artery. Let's see the renal artery stenosis diagnostic criteria with the indirect method. We have an acceleration time over more than 100 milliseconds. The acceleration index is less than 300 centimeters per square second. We have a loss of initial systolic peak, and we can obtain a parvus-tardus pattern with a low resistance index, less than 0.53. We have here an example of the indirect method. We have an abnormal wave pattern, and we can see here a prolonged acceleration time of 329 milliseconds, and we have decreased acceleration index of 149, according with the two criteria I already showed you in the previous slides. And here we have the renal artery stenosis diagnostic criteria with the direct method: systolic peak over 200 centimeters per second, renal aortic ratio over or more than 3.5, aliasing with color Doppler in the segment or in the portion of the renal artery with the stenosis, angle correction. The best angle is 60 degrees, but you can decrease this angle to 30 degrees. Let's see an example with the direct method. We have the renal artery with aliasing. Then we placed the sample volume and we obtained this spectral analysis. A very high velocity with 337 centimeters per second. All the spectral window is plenty of turbulence, and it means that we have a significant stenosis in this portion. Let's see the aorta spectral wave. The aorta has 72.5 systolic peak. And then we will divide both measurements, the renal aortic ratio, and the value is 4.6, which is more than 3.5. Another example, but this case is a fibromuscular dysplasia. In both kidneys, we found parvus tardus spectral wave. And here we found aliasing in the renal artery, and the spectral analysis showed us a very high velocity of 350 with a lot of turbulence, indicating stenosis. Another example, this is a parvus tardus wave inside the kidney. Here we can observe the aliasing, and here with the spectral analysis, we are observing a totally filled spectral window with more than 500 centimeters per second, according with a significant stenosis. We call significant when the stenosis is over than 60%. And in these cases, the velocity is over than 200 centimeters per second. In the past, we sent these patients directly to the hemodynamic lab in order to do an arteriography, but not for diagnostic, but to repair the artery with a stent. It is currently a good practice to place a renal artery stent in. In the past, the study STAR said yes, and this study was published in 2009. Also, the Astral study said yes, also published in 2009. But the Coral study said no, and it was published in the New England Journal of Medicine in 2014. They did this study in order to demonstrate if really a benefit can be found by placing a stent in the renal artery. And the conclusion was no. So in this moment, no many labs are placing a stent in the renal artery. The treatment at this moment is the renal sympathetic denervation. The idea is to interrupt the activity of afferent and efferent sympathetic renal nerves by the use of the radiofrequency energy or ultrasound energy or injection of alcohol into the perivascular space. This is a very effective and safe treatment, but better results can be obtained if second generation devices are used, according to the literature, recent literature. Doppler versus arteriography has a sensitivity of 98% and also a specificity of 98%. So it is a very good method. With no doubt, Doppler is the first choice method for the assessment of renovascular hypertension, but it's necessary to have a trained operator and a proper equipment. In conclusion, Doppler is an excellent method for detection of renal artery stenosis. In our lab, the diagnostic is done by Doppler using aliasing velocity ratios. If Doppler's results are normal, we stop the imaging evaluation in most cases. But remember, you can find false negative cases in 12 to 32 per 1,000 cases. So, my dear friends, thank you so much for your attention. And thank you so much for the organizing committee for the kind invitation.